Thank you.
Hello, Prof. Gay.
Good morning.
Good morning. Oh yeah. Oh yeah. Dia moderator. Kamar kecil.
Recording in progress.
Hello, good morning and good afternoon. Prof. Guy. Prof. Guy, okay. Prof. Kieran. Would you like to test the audio sound?
Yes, good morning, everybody.
I can see, I can
And
hear
good
you
afternoon.
clearly, okay. Miss Wilailuk, can we test your audio?
Good afternoon,
Yes,
everyone.
can you hear me?
Yes, very well.
I can hear you very well too. Thank you very much. Good to see you, to all of you. Can we start now?
Yes, I'm not sure if it is for me to start or for Professor Ali Gufron to introduce proceedings.
Yes, okay. We will start in 3 minutes again.
Okay.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon to all of you and also wishing you a very good morning at London time. I'm Dian Jabar Syabani, your host today at this international webinar on healthcare and customer service. Today's webinar can certainly be held because of good cooperation between BPJS Kesehatan and the countries that present today. Ladies and gentlemen, today in this webinar, we will have presentation and discussion about healthcare and customer service from 3 countries, England, Thailand, and Indonesia. And we are so honored to have speakers today, our special distinguished speakers from NHS England and HSO Thailand, and also BPJS Kesehatan Indonesia. But first of all, I would like to invite Professor Ali Gufron Mukti, President Director of BPJS Kesehatan, to deliver his welcome remarks. Prof. Gufron, time is yours.
Hello. Okay. Thank you very much. Honorable Prof. Guy Dali, Deputy Vice Chancellor for Coventry University. For a long time, we did not see each other. And Honorable Professor Kieran Patel, Deputy CEO of NHS England. Sawadee Krap, Ms. Valelo Vasasa, Acting Director, Bureau of International Affairs on Universal Health Coverage and HSO Thailand. Honorable Dr. Lily Krishnawati, the Director of Healthcare Services Assurance, BPJS Kesehatan Indonesia. Honorable Bapak Mundiarno, the Director of Supervision, Inspection, and Interinstitutional Relation, BPJS Kesehatan. Also, senior leaders, distinguished ladies and gentlemen, a very good morning, good afternoon to all of you. On behalf of the BPJS Kesehatan, it is my privilege to give an opening remarks and warm welcoming in international webinar of strengthening healthcare and customer service. The webinar is hosted as the part of the implementation of the minutes of meeting agreement between BPJS Kesehatan Indonesia with NHS England Coventry University in 2018. Several years ago, I was in NHS together with our colleague from Thailand, and I was the only one person from Indonesia at that time. BPJS Kesehatan is also in progress to make a memorandum of understanding with NSSO Thailand in the field of social health insurance system. And we are hoping that the MOU will be signed by both of the organizations in near future. Today, we are hosting an international webinar as a starting point for the knowledge exchanges among social security organizations. The theme of the webinar is healthcare and customer service. Improving access to healthcare services for all through universal health coverage is one of the main targets of Sustainable Development Goals. As we know that several years ago, WHO has also in the anniversary took the theme that everyone, every person, everywhere, every time has to have access of essential healthcare without financial hardship. And of course that the ultimate goal of the social health insurance is to provide affordable, cost-effective, and equitable healthcare for all people. Many health social security organizations have conducted a series of health reforms, and the insurance coverage is almost universal around the globe. The rapid expansion of health insurance coverage has improved the availability of health services. A major lesson we can draw from other countries' experiences is that, as mentioned by the Director General of WHO, that the universal health coverage should be homegrown. It means homegrown, it means that it should be developed according to each of the country's history, country's economic, country's capacity, social, cultural, and institutional background. Of course, it is difficult to offer propositions which are pertinent for all kinds of the countries. So there is no one size fits for all. Many countries have established what is often referred as the essential package, which should be covered. The latest health technologies and certain medical services that save individual lives may not be represent the best value of efficient healthcare. So it is very important to be analyzed using technology assessment approach, and all stakeholders, patients, providers, politicians, social security institutions, and government typically need to be involved in discussion of the cost versus effectiveness or cost effectiveness analysis, as I mentioned. Appropriate strategic purchasing is really crucial and essential to ensure that desired health services are available at affordable cost. And of course, different methods can be used. Various provider payment mechanism may be adopted. Options include a type of modification of fee for service payment, capitation payment, and diagnosis-related groups, and global budget, where now in Indonesia is trying to piloting it. Some health insurance system contract with preferred providers, while others are required to work with all legally registered providers. The duty to share information and experience between social health insurance around the world, I think, is very, very important, that we can, improve the quality of care as well as how to control the costs, where always that resources limited. And of course, it is also our duty to protect patients and citizens. Hence, BPJS Kesehatan hosting the international webinar to facilitate the best practice sharing between countries, considering the mutual interests and goals of the institution to strengthen health insurance system in each country. And I personally thank you for Coventry University, Prof. Gaidali, for your, initiative, the time to provide me a doctor honoris causa, because of your consideration that my contribution in developing social health insurance, especially for the poor in Indonesia. Thank you, and have an amazing webinar to all of the audiences. We hope that this seminar will provide and have a good result to learn together, to exchange the experience and knowledge, and stay safe and healthy. Thank you very much.
Thank you very much, Professor Gufron, for your wonderful remarks. And also here with us today, Mr. Mundi Harno, Director of Supervision, Inspection, and Interinstitutional Relations of BPJS Kesehatan. Good afternoon to you, sir. I hope you enjoy this webinar. And ladies and gentlemen, we are proceeding to the main event today. We have all the speakers here. Mrs. Lily Krisnawati, Director of Health Service Assurance of BPJS Kesehatan Indonesia, Professor Kieran Patel, Deputy Chief Executive Officer of NHS England, and Ms. Wilailuk Wisasa, Director Policy Advocacy Unit of NHSO Thailand. This discussion will be conducted by Prof. Guy Daly, Deputy Vice Chancellor of Coventry University. Prof. Daly, how are you, sir?
I'm very well. Thank you very much. Lovely to see you and to see other colleagues, and great to see Prof. Ali Gufron Mukti, who I've not seen for a long time, but a very close friend.
Okay, thank you so much, Prof. Daly. I think you are more than ready, and time is yours.
Thank you very much. So just to really welcome everybody again to this very prescient webinar. Never has effective health care and health protection been important as it has been over these last few months and nearly 2 years now, as we've all been coping with the pandemic. So it's a great pleasure and privilege for me to act as the convener of this webinar. And as has already been said, we've got a fantastic lineup of speakers who will be able to give insights from Indonesia, from England, and from Thailand. And always we are here to learn from each other and to work in partnership. I think, as I've said, all health systems have had to face, if you like, unprecedented challenges over the last 18 months or so. And never has it been more important, therefore, to have universal health coverage systems in place, whereby we do have both public provision and public coordination of healthcare services across countries. But also, I think what we will hopefully explore is that in order to cope with the challenges we are faced, it is not just about the effectiveness of health services, but also about tackling some of the social determinants of health inequality, which are not solely the responsibility and the purview, as it were, of healthcare systems, but also of the wider socio-economic, global political systems that we face. So that's enough from me for now, I think. I hope that everybody will enjoy the presentations we're about to hear. Each of our speakers will have approximately 20 minutes to cover their perspectives from their countries. We will start with Ms. Lily Krisawati in a moment or two, Director of Healthcare Assurance, BPJS Kesehatan, Indonesia. Followed by Professor Kieran Patel, my friend and colleague from England, Chief Medical Officer and Deputy Chief Executive of University Hospitals Coventry and Warwickshire, and previously Chief Medical Officer of NHS England in the West Midlands. And then from Ms. Walauka Wisasu, Director of Policy Achieving Unit NHSO in Thailand. I'm sure that all of our speakers will provide thoughtful, insightful perspectives that we will all benefit from. So thank you for joining us this afternoon and this morning. Trust that it will be informative, exciting, edifying. And without any further words from me, I'd like to hand over to Ms. Lily Krisawati, Director of Healthcare Assurance, BPJS Kesehatan, Indonesia. Thank you. I think in a moment, Ms. Lily will join us.
Can you hear?
Yes.
I'm sorry for this inconvenience. Okay.
All is good.
Yeah, thank you. Good morning, everyone, and good afternoon in Indonesia. First of all, I would like to thank Mr. President Director of our BPJS Kesehatan for the opportunity to presenting the BPJS Kesehatan in this webinar. May I share our presentation, please? Yeah. Thank you. I would like to present how the role of BPJS Kesehatan in Indonesia in improving healthcare services. Next slide. There are two main outlines for this presentation. The first is to introduce the National Health Insurance Program in Indonesia, which is called JKN. And the second is the Improving Healthcare Services in JKN program. Next slide. Yeah, next slide. National Health Security Program in Indonesia is called JKN, or Jaminan Kesehatan Nasional. BPJS Kesehatan, as administrator body of JKN, runs this program based on regulation that created by the government, consists of benefit package, provider payment rates, scheduled payment setting, and also the subsidized recipients, which consist of poor and near poor people, that contribution is paid by the government. In this framework, we can see that the three parties there, the first is members who pays contribution regularly, either by themselves or paid by the government. So the members can have access for health services delivered by healthcare provider. And after the service has been rendered, the healthcare provider will submit claim and report to the BPJS Kesehatan as administrator, who then verified and pay hospital claims on scheduled time. And BPJS Kesehatan also manage the administration and handling complaint from the members of the JKN. Next slide. As you see, the healthcare services in JKN has divided into 3 tiers, which is primary healthcare, secondary and tertiary healthcare. Because the scope of JKN program includes the promotive, preventive, curative, and rehabilitative, so the gatekeeper concept should be implemented in this area. The primary healthcare will take the first healthcare services to ensure that our member get the basic health services needed. On certain conditions that could not be handled by the primary care, then the member will be referred to the secondary or tertiary healthcare providers according to the service needed. And after the medical condition have been treated and stabilized, the member will be reversed back to primary healthcare reverse referral program, which is called PRB, reverse referral program. The payment system in the primary healthcare is capitation in general, and there are some service that is paid fee for service or per diem, such as PRB drugs and also inpatient primary care. As in secondary and tertiary healthcare, the payment system using the INA-CBGs or diagnosis-related groups, and some service is paid fee for service, such as chemotherapy, some non-stable chronic drugs, and also certain drugs such as for hemophilia or thalassemia. Next slide. JKN program as a social health insurance security in Indonesia has 3 main focuses, which is risk pooling, revenue collection, and purchasing. In this term, BPJS Kesehatan is supposed to be a strategic purchaser. But as you see in the circular picture in the left, that we are somewhat different from other countries. The benefit package and the payment rate is set up by the Ministry of Health. So, and while premium rate is a national consensus from multiple stakeholders, so the BPJS Kesehatan is doing the contracting providers and doing provider payment methods. So in order to ensure that the sustainability program is sustained, we have to improve healthcare within quality controls and cost containment. And our duty is in charge of selecting, contracting, and also doing the payment of provider. Next slide. Yeah. As you see the profile, Indonesia is a vast archipelago country with a distance from easternmost of Merauke to westernmost of Sabang is around 5,120 kilometers. It's like the distance from London to New York, actually, and consists of 17,691 islands all over. The member of JKN now have reached 225 million out of more than 272 million populations, or around 83% of the total population. The member consists of 50.83% men and 49.17% women. If we look at the profile of the participant, there are 43% of the member registered and paid by the central government, or we call it PBI APBN, the subsidized person, which consists of poor and near poor people. And then 25% are formal sectors, 16% is registered and paid by local government or subsidized government, local government, and 16% more are informal sectors. As our healthcare facilities, we have 23,043 primary healthcare facilities, consist of primary healthcare centers, private general clinics, and private general practitioner. And there are 2,507 secondary healthcare providers, consist of hospitals and specialist clinics. There are 1,400 pharmacy, and we BPJS Kesehatan have around 1,263 verification staff all over Indonesia. Next slide. As we see in the graphic here, since 2014, the utilization of JKN program constantly increased, with the exception in 2020 due to pandemic COVID, where most of the patient avoid or fear to contact the physician in hospital, except for the patient who still have to access hospital, especially for those who have chronic disease that requires routine checkups to monitor their health conditions, and also some emergency cases. The decrease in healthcare utilization is a blessing in disguise that caused a positive cash flow for the Social Security Fund, but nevertheless, in 2021, BPJS Kesehatan keep monitoring the utilization data to anticipate the rebound phenomenon after pandemic. The use of quality control and cost containment principle in JKN program are to ensure that the program can sustain for long run, and in order to do that, BPJS Kesehatan do the utilization review routinely. We monitor those data regularly, and we also have application dashboard for local government so that they can monitor the data related to their population and utilization of healthcare services, so that they can create an evidence-based policy in health sector as well. And BPJS Kesehatan also enhanced the teleconsultation and telemedicine services to bridge the physical gap between patient and doctors. So we ensure that the patient will still have access to the healthcare services, even though they're not coming to the facilities during the pandemic. Next slide. The second outline is improving healthcare services in JKN program. Next slide. Yeah. In JKN healthcare ecosystem, we focus on customer and provider journey because the participant satisfaction is one of our main goals. BPJS Kesehatan has developed the mobile application named JKN Mobile that links to another application such as online primary care, online virtual claim, and health facilities information system. Our member can download and access that application to get some benefits such as teleconsultation with the family doctors. They can also see their history of care, and then the availability of beds in hospital, and even doing self-assessed screening for certain potential disease. For queuing system, we developed the system through mobile JKN, where the member get the booking number to access to primary healthcare or secondary healthcare via mobile JKN. This will shorten the waiting time of patient receiving care, thus to avoid direct contact with too many people in one occasion. This is important in the era of pandemic. And the healthcare facilities has also gained benefit from the application since it is integrated with the facility systems. They don't have to manually record the service such as teleconsultation. It will automatically record it in the system and thus record it as their activity of care and will improve their performance. The digital ecosystems in BPJS Kesehatan plays important role because we have large number of social health insurance member all over Indonesia, and also our geographical settings that consist of thousands of islands. So in this digital ecosystem, we can the member can get the service, and the health facilities can also record the service easily and make a claim to BPJS Kesehatan via online. So this is the virtual online claim. This is also important because we can, in this integrated system, we can also implement the quality control and cost containment. This is our area to further improvement and development. Okay, next slide. Okay, before pandemic, we have in membership administration aspect, we have a program named BPJS 1, BPJS Siap Membantu. That means our officers are readily help JKN participant when they experience issues with hospital service. We also conduct routine monitoring and coordination with hospital officers to make sure that the JKN participant get a good quality service. And we also have this routine survey for the facilities to make sure that they know and they have the same or the right perception and knowledge about the policies and regulation within the JKN. In the pandemic era, we developed the provision of participant administration service without direct contact, or we call it no face-to-face service. The first is administration, information, and complaint services using the JKN mobile application that is easily to do for the member. And we also provide administrative services via WhatsApp in all branches offices in all over Indonesia. There are 127 offices that has this service. And we also have a care center 165, which is integrated with social media. This number, this short number was meant to give more easy to use for member. And we also provide the chat assistant JKN via Facebook Messenger, Telegram, and WhatsApp in certain numbers that we call Chika. Okay, next slide. In terms of quality control and cost containment in JKN program, sorry. Okay. In terms of quality control and cost control in JKN program, BPJS Kesehatan divided into 3 areas. In input area, we do health facility credentialing and re-credentialing. And we also do cooperation agreement with healthcare facilities and contracts. And then in the process, we arrange referral systems that is based on competency, and we also provide the most accessible range of hospitals within the systems. We also do some standardization of health service guarantee, and we intensify the promotive and preventive care. We also use digitalization for service, and we do the payment based on performance with several criteria. And we do claim management and walkthrough audit, and also we conduct health facility compliance assessment to make sure that the facility conduct the service within our agreement in the contract. And as the output, we do routinely utilization review and also post-claim audits and fraud detection system. We developed this kind of application that would detect several outliers or abnormal patterns in the claims so that we can go for in-depth investigation for potential of fraud. And we also involved several stakeholders of JKN program to give control and support for implementation of JKN program, such as ministries or institutions. We also involve local government, for instance, for mapping and also doing credentialing and re-credentialing, and also in handling contract with selected facilities. We involve the local government and health facilities association. And we also involve the profession organization and also local government doing the or becoming our team of quality control and cost containment. So we supervise together how the facilities deliver the service to the member of JKN. So this way, we ensure that the accessibility of the service and the health service quality control is managed. And on the other hand, we ensure the contract with selected health facilities is according to the policy and regulation. Next slide. Excuse me. Okay. Now, how we manage health insurance, enhancing the efficiency and effectiveness of service delivery. The strategies carried out by BPJS Kesehatan to manage the effective and efficient healthcare services includes the credentialing and re-credentialing for health facilities that is contracted with BPJS Kesehatan. And we also doing the disease management programs for chronic disease such as type 2 diabetes and hypertension patient. And we make sure that the first or primary care facilities has the program to maintain their members to get control of this chronic disease. The reverse referral programs is doing for chronic disease patient in stable condition, so that after the patient is stabilized, the hospital or the secondary and tertiary facilities have to refer back to the primary healthcare facilities to be maintained by the family doctors. The teleconsultation service in primary care facilities is enhanced during the COVID-19 pandemic to ensure that the patient will still have access, will assured for their access to healthcare, even though the pandemic restricted them to go outside their house. So the teleconsultation will fill in the gap for the access of primary care. And we also doing performance-based capitation to link the payment with the performance in primary care facilities. As we say, the teleconsultation is also be beneficial for the primary care, because they don't, even the visit of the patient is low during the pandemic, they can still reach their patients or their member through the teleconsultation, and it is automatically recorded in the primary care systems. So it is considered as their activity in delivering service, and so it will increase their performance. So it will improve their payment also. So this is a very beneficial for either the patient or the facility care. And we also make digitalization of billing and claim verification is also to make easier for the facility to submit their claim without doing it manually and without coming to our office. The digitalization of the referral system is also how we manage the efficiency and effectiveness. So with this referral system, we don't need to be paper-based anymore. So the primary healthcare system, the primary facility care is only put or entry the data into the system to make the referral, and then it is automatically will be read by the tertiary, secondary or tertiary facilities that is being referred. So it will be more easier and more efficient to do the referral system, and also the reverse back program. Yeah, next slide. How we improve the quality of primary health services. In primary healthcare services, BPJS Kesehatan has developed and implement time management of participant or patient health services with online queue system, as I mentioned before. In pandemic era, this is very important because less direct contact, and to protect our member from infection of COVID-19 as our focus. The member can also access teleconsultation service in mobile JKN. Online queuing system of primary healthcare providers that has been connected to the mobile JKN application has been used by around 18,022 primary healthcare providers, or already 79.2% of the total primary care providers. And the improvement of promotional and preventive services through teleconsultation service is also conducted by this mobile JKN. Since March 20 to July 21, there are 7.74 million teleconsultation services using primary healthcare communication media has been conducted. Specifically for teleconsultation using mobile JKN, there are 9,656 doctors on primary healthcare have used it. And also during the isolation, self-isolation for the COVID-19, it is also used by the doctors to monitor their patients at home. Next slide. In the referral healthcare services, besides the online queuing system that is also already implemented in 95% of partner hospitals, and 877 hospitals have been fully integrated with mobile JKN. Optimizing the implementation of online queuing system is necessary to improve customer experience or customer journey, to reduce the waiting time, and to ensure that the participants have immediate access to intended services. Information of the availability of beds in hospital is also has been implemented in 97%, in which 60% of hospital updated once in 24 hours. The challenge is related to the compliance of data updates by the hospitals so that they can meet the needs of participants. And this is becoming area of compliance that we are routinely checked from our facility. And also the display of operation schedule information in hospital has been implemented by 47% hospital. So it will give transparency of surgery waiting list for the member. Next slide. Yeah, this is quite much. I think the impact of JKN on numerous sectors as we can see. The first, JKN has increases the healthcare utilization, improving access to healthcare. The second impact is improvement in healthcare access led to improvement in life expectancy also. A simulation of achieving 100% coverage will increase life expectancy by 2.1 years. The third impact is improvement in life expectancy led to increased productivity and economic growth. A simulation of achieving 100% coverage creates 3.1 million job opportunity and contributes to 212 trillion rupiah or 14.6 billion US dollar worth of output. A simulation of 1% increase in JKN membership will increase a GDP per capita by 1 million rupiah or around 70 US dollar per year. Micro simulation showed that JKN prevents 8.1 million people from impoverishment due to catastrophic health expenditure. In 2019, there are more than 45 million Indonesians use JKN. And around 17% out of 45 millions were prevented from impoverishment due to health expenditures. This is the source of Indonesian University Studies in Faculty of Economic and Business. Next slide. From this presentation that I have presenting before, let me share the lesson learned or the conclusion from this topic based on our experience running this program from 2014 until now. The first is strong commitment from the government and support from all stakeholders are needed for JKN quality health services. And this is a must because our JKN program has multi-stakeholders. So we focus to increase engagement in stakeholders so that everyone feel that JKN program is belongs to everyone in Indonesia. The second challenge in the quality service delivery is the limitation in the resource. So there are some efforts has to be done to ensure quality and effective utilization are urgently needed. The quality control and cost containment principle are used to ensure that the sustainability of this program is maintained. Last slide, okay. Maybe, yeah, okay. Thank you for all your participation, and I will be glad to get involved in the discussion furthermore. Thank you, Mr. Guy. I present back to you.
Thank you so much, Lily Kranasati. Terima kasih. I'm going to move us immediately to my friend and colleague, Professor Kieran Patel, for his presentation. Good morning, good afternoon, Kieran. Over to you.
Good afternoon, Guy and colleagues. It's a real pleasure to be with you today, and I will attempt to share my screen. And are colleagues able to see?
We have your presentation, Kieran, in front of us. Thank you.
Great, thank you. So I'm going to give you a very quick canter through the NHS, the National Health Service in the UK, and talk about how we've established universal healthcare over the last almost 75 years now. Just try to move that on.
Yes.
Yes, so the NHS provides universal healthcare, esteemed to be a service that cares from cradle to grave. It is free at the point of need, so people don't end up with out-of-pocket expenditure, which generates impoverishment and inequality. So it's a very laudable system that was established in the earlier half of the last century. It is funded by the taxpayer, and in fact, the population in the UK is very passionate about the NHS being an institution that we are very proud of, and we are very proud to have. There is also a small private sector that functions in the UK, but essentially a taxpayer-funded healthcare system is one that everybody contributes to and benefits from. And we have constitutional rights within that in terms of entitlement to primary care, to elective care, and to surgical care. Now, one of the things we need to do is make sure that we have quality governed within that system. So the NHS not only delivers universal care, but is driven by a review of outcomes and quality within the system. For a relatively low GDP expenditure, so whereas in America we are seeing up to 30% of expenditure allocated towards healthcare, here we have just over 7% at the moment. Now, we have devolved a lot of responsibility from government to the Department of Health that has been established, and that holds the National Health Service accountable for delivering what are seen to be political priorities and constitutional rights within the NHS. And the NHS is accountable to Parliament for delivery of its services through a Secretary of State. Now, if we look at spend on health, as time has gone on over the past decades, we've seen an exponential rise in healthcare. Healthcare is becoming more and more expensive, and therefore to deliver not only basic universal healthcare, but actually healthcare at the horizons of medicine, which is progressing at a significant rate, we will need to allocate more and more of our GDP towards healthcare. And that is true for every economy in the world. Now, add on to that, we have economic changes and cycles within each of our economies. We are seeing that, I'll just put this on. Yep. We see an increasing expenditure in absolute terms in healthcare. That is subject to a cyclical change economically in terms of income. But then we add to that the need to increase expenditure, which is justified by many factors. And I've just listed a few of them on this slide. So there is a demographic change. The population gets older. As it gets older, the number of sicker people with comorbidities increases. There is an expectation, as we heard from our last speaker, that digital healthcare starts to be enshrined within healthcare delivery. Patient expectations inevitably increase. There is a culture that people feel there is a right to get certain treatments within certain times. And at the moment, post-COVID, there are some significant challenges with delivering those. And of course, there are political policies that have to be delivered. Those all cost money. And then, of course, we do that within the constraints of limited resource. So we are driven to become more and more efficient on a background of increasing expectation and change in a continuous cycle. So there are challenges for the NHS. There are economic challenges. How do we encourage the public to invest more of its tax resources within the healthcare system? At the moment, we've had an increase of 1.5% in our taxation to cover the COVID pandemic. And the public seem to be quite content with that, but it doesn't go without debate. There are other issues. So, as I've said, moving from a population profile that has changed significantly over the last 3 decades to caring for older people. So it is not specific healthcare that's required at the moment. Actually, social care needs are becoming increasingly important to make sure that we don't use healthcare resources for social care. And then, of course, we need to adapt technology and genomics that are on the horizon. We need to move from a 5-day service to a 7-day service. People don't choose when they want to become ill. And of course, there is always the mantra that we need to strive more and more to prevent illness rather than cure it. So we need to identify where and who we tackle in terms of preventative measures. And there is always the risk that we have too much medicine in the system. So as we provide more healthcare technology, there is a risk of inappropriate utilization. So we need to guard against inappropriate utilization of very scarce resources. So of course, we've had the COVID pandemic, and it would be remiss of me not to mention that pandemic. and we have two significant challenges. First of all, I'll take non-elective care. So patients are now starting to present with urgent healthcare needs, and that is putting immense pressure into the National Health Service because people didn't present to our emergency departments and our GPs as they should have done throughout the pandemic. They were either scared or they were asked not to present. And because of that, we are seeing more emergency care needing to be delivered. But in addition, there is a huge backlog of elective care that hasn't been delivered. So our challenges are going to be very significant over the coming years, and depending on which experts you speak to clear that backlog may take anywhere between 2 years and up to 10 years in the National Health Service. And to accommodate that, we need a paradigm shift. And these are my opinions. We need to move from everything needing specialist care to accommodating the generalists more, and using our primary care system to generate more of a gatekeeper role whilst not prohibiting access to good specialist care. We do inevitably make things very complex when sometimes they could be simple. So we need to address what it is that patients want rather than what it is that as clinicians we feel need resolving. We need to move from just trying to do lots of things to doing things that improve quality of life at the moment and what patients need. And I think, the days of randomized controlled trials are really numbered. I heard a colleague saying that it would take almost a decade to go from trial design to getting that into practice. Whereas now, if you look at social media, things are adopted almost instantaneously around the world. And we've seen that during the pandemic with people empirically trialing therapies that have almost been quackery or opinion around the world. But that can be a huge consumption of healthcare resource unless we guard against it. And we need to move from providing care in very high-tech settings to actually giving care at home where it's possible, because that is much cheaper and it has a vast socioeconomic benefit. And then, we need to think of ourselves as providing services rather than consultations. So, move away from the fee for consultation service to a fee for an outcome. And I think that is a paradigm shift. And again, if we are thinking holistically, move from treating patients to treating people. So in the UK, the next slide is just a pictorial representation of how the Department of Health is organized. We have lots of arm's length bodies which deliver for the National Health Service. And I'll go through these very quickly. So NHS England is the body that commissions services from healthcare providers. So whilst our hospital trusts are public bodies, general practitioners are sole contractors into the NHS. So they provide services for the NHS. Health Education England looks at workforce planning and commissions education and training from our universities, like the one that Professor Daly resides over in Coventry. And then we have Public Health England, which looks at population health. Then added to that, we have arm's length bodies which look after very specific things. So NHS Digital looks at digital development. NHS Improvement looks at licensing of provider organizations within the system. And the National Institute of Healthcare and Clinical Excellence looks at setting standards and developing evidence for implementation within the NHS. And then, of course, the Care Quality Commission looks at inspection and maintaining standards within the National Health Service. Now, in the interest of time, I won't go through how the UK health system wants to help developing healthcare economies to generate universal healthcare, but there is a lot of literature and policy around the Prosperity Fund, which has chosen some healthcare economies around the globe to work with, particularly in its first wave in Mexico, Brazil, South Africa, and then a range of countries in Eastern Asia. And of course, we would wish to help colleagues across Southeast Asia to benefit from what we have available to offer here. So I'm going to go on to talk about strengthening healthcare systems. Just get that slide up. Just a little lag on the slides, but I think a really good way to think about how we develop and universal healthcare and strengthen systems is the WHO pillars, which are sixfold: looking at service delivery, looking at the healthcare workforce, looking at information, looking at medicinal products and technologies, and then looking at finance. So I'm going to move on. I think there's a slight lag in the slides. There we are. So those are the 6 pillars we've got. And then I'll move on to my next slide, which really talks about stakeholders and how we help to tackle this. So there will be government support across the globe to help developing economies, but also thought leadership from organizations like the universities in the UK, think tanks and research organizations, and that will be married up with delivery partners who are NGOs as well as government organizations. So in terms of technical support, we are here to develop strategies in both communicable and non-communicable disease. It is really important to look at the needs assessment for a country. So a public health profiling of the population followed by the need of that population helps to allocate resources effectively and efficiently across government. And I think coupling that to quality improvement within the system as well as education and training is imperative. In the interest of time, I shan't go into the next few slides. I'll just really focus on health education England, the role and the expertise. So one of the biggest challenges we have across the globe is healthcare workforce, in that we don't have enough of it. And I think that will be a primary driver of our limitation in the ability to deliver universal healthcare, as opposed to money. We often think about money and economics being the constraint, but I think very shortly we'll be able to say that we have the resource, but we don't have the human workforce to deliver healthcare. So planning ahead for workforce becomes critically important. So health education England in the UK, in terms of planning ahead over the 5 to 25-year horizon, is incredibly important. You know, we will not have a workforce in 5 years if we don't put those individuals through our universities today. And we've got to manage what that profiling looks like now in order to meet the needs of 5 years' time. So I should move on. Yeah, I'll move on to the next slide if that's okay. Okay, so I think I've covered that. I'll move on to the policy needs. So let's wait for that to come up. Carry on to policy needs, please. So in terms of policy, I think when we are developing healthcare and universal healthcare in particular, we need to make sure that it's built on the foundation of scientific credibility. Otherwise, we risk using resource, be it fiscal or workforce, inappropriately. We need to make sure we have financial feasibility, so to define the envelope that we have so that we can develop services within that. We need to make sure that we have the ability operationally to deliver what we want to deliver. And we need to make sure we have political support for developing and delivering our vision. In terms of workforce challenges in our low and middle income countries, on the next slide, please. As I've said, it is short in numbers. There is a risk that it will always be concentrated in cities, which generates inequality, and that it may be concentrated in the private sector. So we have to have really clear strategies to prevent that. Training can often be privatized, and I'm really proud in the UK that the majority of our training is not in the private sector, but it is standardized within the government sector. And the risk is if you have a centralized and privatized workforce, that the rural workforce is often untrained and unregulated and of a different quality. And of course, economics forces migration of workforce. So I think it is good to plan for an oversupply of workforce than an undersupply. And if we are smart in developing workforce, it can become an economic export potential. So in terms of strengthening health systems, I think we should look at the causes of disease, the consequences, and the health status of our population, as we've discussed earlier. Going on to the next slide, financially, I think we've covered, we need to be very clear and comprehensive about what we have, and we need to avoid impoverishment. Out-of-pocket expenditure drives poverty, which drives healthcare need, and it's a vicious cycle of deterioration. And there are many countries around the world, including India and Pakistan, where we've seen the adverse impact of getting the financial envelopes wrong. Going on to talk about medical products and technologies, we need to think about procurement as well as delivery, and the fact that we mustn't concentrate the delivery of procured resources in urban areas. And then going on to talk about prevention, treatment, and management of chronic disease. These are all parameters that we need to be very clear and conscious about, ranging from prevention and proactive case finding early, so that we prevent a drain on our resources by having some very late stage diseases that we have subsequently. So I just wanted to finish with a few slides on health inequalities, and these are unacceptable disparities which we all have to contend with. And I think it is really important to build a universal healthcare strategy based upon healthcare inequality. If I went through the last 30, 40 years in the UK on the next slide, I'll show you the list of reports that has been available in the UK trying to tackle health inequalities. So I won't say that we have it perfect by any means. We've always had the desire to tackle this, but I don't think we have fully succeeded. But post-COVID, I think we're in a world where we genuinely need to start tackling this. And the next slide just pictorially represents what I mean by this. You know, if we don't get it right in terms of meeting the needs of our most vulnerable, next slide, please. If we don't get it right by meeting the needs of our most vulnerable, then the inequality will widen as we go on. And I'd like to see both of those arrows head in the right direction, but the rate of improvement for those most in need has to be greater than the rate of improvement for those who are the healthiest in our population if we allocate resources equitably. And on the next slide, this just demonstrates the disparities driven by COVID-19. And we looked at this last year academically. And actually, if we look at the drivers of disparity in outcome from COVID-19, they are no different to the drivers of healthcare inequality in the UK. And that was shown much earlier by Dahlgren and Whitehead on the next slide. And this was literature that was published almost 30 years ago, showing us that the drivers of health and disease, and the next slide, please. The drivers of health and disease are driven not only by biological factors, but actually many factors out with the control of the healthcare system. So as a healthcare system, we only have about a 10 to 15% ability to influence health outcomes. So in order to really improve health outcomes, you've got to work across government agencies and sectors to improve all of the social determinants such as housing, water, sanitation, living conditions, etc., in order to improve health outcomes. So I'd just like to finish by saying that really developing a universal healthcare system needs clarity. It needs equity of outcome, but inequity of approach for your population, and funding within a very clear envelope. Thank you, Professor Daly. I will finish there. Thank you for allowing me to present.
Thank you. Thank you so much, Professor Kieran. To ensure that we have sufficient time for questions, I'm going to move us next to our third and final speaker, Ms. Walaku Wisaru, Director of Policy Advocacy Unit, NHSO in Thailand. Ms. Walaku, over to you, please.
Thank you. Thank you for BPJS Kasatan allow Thailand to, especially NHSO, to share our Thailand experience. May I'm sharing. So
yes, we can see your slides. Okay.
Okay. Thank you. My presentation will be background and health system, universal coverage system, universal coverage against with COVID-19 and the challenge. Let's start with the background of Thailand. Thailand is upper middle income countries, which a high level of health achievement in terms of life expectancy and mortality outcome. Universal health coverage was achieved by 2002 with a comprehensive package and almost zero co-payment at point of service. Health expenditure is around 4% of the GDP, and our pocket is very low, around 11% of health total health expenditure, while public health expenditure was only 70% of total health expenditures, up from around 56 in 2001, where we have a universal health coverage. Key principle to building a solid platform to move forward universal coverage in Thailand, especially in the starting point, does not put more focus on only financial protection, but be priority more on develop of healthcare system to ensure universal access to service for people. You can see when we for the USCQ, we can achieve to access. I will show you. So it's not move. Next, I will show you the health system in Thailand. In Thailand, the administrative level we divide to region, province, district, sub-district, and the smallest is village. For health service development since establishment of Ministry of Public Health in 1942, the government has policy to scale up both health delivery and health workforce, especially in rural area. To work is mandatory to work in the rural area for 3 years after they finish from medical school or nursing college, and scale up number of district health system. Also, the government have policy to promote strengthening primary care since 1978. You can see, as I mentioned you, the administrative level for delivery system in each level, because of the policy to scale up of the health system. So every level, we will have like a sub-district. At least one sub-district will have one health center. In district, we'll have at least one district hospital. And in the provincial level, it can have the regional provincial hospital, and also in the national level. In our system, we have both private and public involved in the system, but mainly is dominated by public hospital under the Ministry of Public Health. This is the picture of the health system delivery. We divide in each level because in our system, we promote for prevention promotion. So each health facility will have a catchment area and catchment population. We set up the standard of workforce. It will relate to the catchment populations and also area. Although some area is quite small, but it's in remote or in Iceland, we will have at least one health facility to provide service for them. So you can see in detail of each level of health facility and including the health workforce in each level. As I mentioned you before, we promote for district health system. So we will work as a network, and it can be monitoring and also supervise them in the district health system. Another important is the referral system, because in Thailand, as I mentioned you, we promote for primary care and strengthening them. And in our system, we compulsory to visit primary care first. If the primary care cannot provide the service, they can refer to upper level. And also, it can refer back to a primary care for continuous care. We learn and we implement the gatekeeper from UK system. Next, I will show you the universal health coverage system and outcome. After we achieved the universal coverage in 2002, you can see that in Thailand is not single scheme different from Indonesian or UK. We have three main scheme because of it have their own acts and developments. So you can see we have a three main scheme. The first one is civil servant medical benefit scheme, cover for government officer and their dependents, parents and children. Second one is covered by public sector. It's covered just only employee under the Social Security Act, which they have a 7 benefit. Health benefit is 1 benefit under the Social Security. Managed by Social Security Office under the Ministry of Labor. And the biggest one is managed by National Health Security Act, is we call universal coverage scheme, because if you don't have the civil servant medical benefit scheme or social security scheme, it will cover by this scheme managed by National Health Security Office. So you can see in Thailand, we have 3 main scheme and 3 purchasers. But when we design the system for universal coverage, we need to remove the financial barrier. So we mainly is tax-based. And we try to set up the governance system. So purchaser provider split is implemented. You can see we have 3 purchaser and provider mainly will be the Ministry of Public Health, because mainly hospital is under Ministry of Public Health. We try to promote for multi-stakeholder governance system. They are the representative in the committee and they can provide a policy for us. Our benefit package is cover comprehensive. We including outpatient, inpatient, health promotion and disease prevention since we start, and also high cost care, dental care, medicine, and operations. The service delivery, as I mentioned you before, we promote for district health system and primary care as the main contractors. In our system, we use for the payment mechanism, we use the closed-end system and mainly for capitation for outpatient and prevention promotion and DRG with global budget inpatient. But in detail, we still have some other payment like a fee schedule, fee for service to incentive for the health facility to provide the service, but mainly is capitation for outpatient and prevention promotion and DRG with global budget in inpatient. And we try to set up to ensure the good quality of health while implement the hospital accreditation, patient safety, quality care, and quality assurance. For the benefit package, as I mentioned, we continue us to develop the comprehensive. In our benefit, we provide a negative list, so it means that we cover all access and co-payment. At this moment, when we start, we co-payment for 30 baht, allow you $1. But at this moment, co-payment is terminated in 2006. At this moment, it's like a totally free of charge. And we try to implement as a health technology assessment evidence for the new benefit package. You can see that as I mentioned when we start, we have just only in 2002, we has just only the basic health care. And when we have the better economics, we the additional benefit package, and also we have to prepare the health system, the health service, and also health workforce, while our benefit package is developed step by step. Like this year, we just provide the automate for peritoneum dialysis. And because of we are not rich country and we use the payment capitation and DRG, so we have to set up the right protection system parallel to ensure that our customer can access to our system and not have any problem for quality of service. So we set up the right protection system. We have the beneficiary system registration. So we have the we can count everybody in our system, and also we have the contact centers 1330 mechanism to provide information and receive complaint in our system to ensure the quality service. So we have a complaint management handle, and also in our acts we have no fault compensation to compensate the customer and provider who receive effect from the system. This is the outcome that you can see that Thailand, we can increase the essential health service. And if we see the financing issue, we can increase, the government try to increase the public health expenditures continuously. And also we found that we can protect our people from health embarrassment household is continuous decrease. And also catastrophic health expenditures, because the health catastrophic expenditure can be bankrupt because of health expenditures. So we found that in Thailand we can protect them. It's decreased continuously, especially when we achieve universal coverage since 2002. And we monitor the utilization rate is continuous increase, although we use the capitations. We monitor both inpatient and outpatient is continuous increase. Not only the overall utilization, we monitor in each group because the need of each group is different. So we monitor the utilization rate in each group, and we found that is continuous increase. And for the macro pictures, we continue as have a satisfaction survey. We survey both customer and providers. It's done by third party, the technocrat institutes. We found that since we start, the beneficiary has a high satisfaction, but for the provider is quite low. But we try to work closely with Ministry of Public Health to incentive and encourage for provider side, so we can continuously increase the satisfaction from provider sides. Next, I will show you after we have the same as both in the world, how USC is again with COVID-19. Thailand is the first country that have a COVID patient out of China. So we rapidly approve COVID-19 as a benefit package, and also the government provide additional budget, not the budget in the health insurance. We cover both Thai citizens and foreigners. Thai citizen will cover by and managed by each scheme, and foreigner, the government will provide additional budget for COVID-19. We cover screening, tracing, quarantine, and treatments. You can see this is the flow of the treatment that I mentioned. We cover the hospital room, meal costs, medical supply, medical fee, diagnosis, etc., including when we have a very high new case, so we increasing the home isolation and community isolation is also can reimburse from the system, both Thai and foreigners. And also for the COVID-19 vaccinations, we provide both for Thai and foreigners, and we found that it has some will suffer from adverse reactions or side effects from the COVID-19 vaccination. So we have provide compensation for the one who affect from the COVID-19 vaccination to the same as we provide the insurance. And we try to implement the new normal medical service in the pandemic period, try to apply ICT and digital health in the service system. Like for example, at cancer, we can provide service anywhere, and also the approved for the home chemotherapy for colons. So we try to increase the access to the system. This is one example for cancers. And also we promote more for mobile application for members. Previous, we already developed, but not worldwide. After we have the COVID-19 pandemic, so we use more for applications, and so the people can access and receive information from the system. And also we try to use because of the technology disruption, so we implement the telehealth, telemedicine. It's very helpful, especially when we implement the home isolation, the community isolation, because we can connect with the patient and also our health professional in our system. We can connect with them, and also we can receive the requirement on it from them. And also the health professional can daily twice consultation with them and can refer if they need to refer to the hospital. And also in the consumer protection, we use more for ICT to support them, and they can connect to our system more. And also we try to monitor the system, because in COVID-19 we have many organizations, not just only health sector. So we develop together and link all system to show in dashboard. So every organization can monitor from dashboard. And this is one example when we monitor to home community and community isolation, because not just only provide the service, but we have to provide like a food delivery, tele follow up, and also medicine supply, etc. So we need to have the system to monitor. And the last is a conclusion from Thailand experience to ensure the quality and good quality service. We found that the commitment of health workforce and also the ethical commitment is the key for health service development and financial protections. And we learned that universal health coverage is context specific. We can learn from other, but we have to adapt under our context. Cannot copy from others. And my last slide, challenge. We found that we still have the challenge as we found that to ensure the access of quality and care and also rapid of health technology. So we need to develop the mechanism for this one. And also in Thailand, for beneficially, we develop like a BB aging society. So we need for the long-term care. And for the financial, we use the tax base. We haven't mainly implement the insurance base yet. So the financial sustainable is the main challenge. So we need to develop another source of fund. As I mentioned, we are 3 main schemes. So we still have to need to harmonize for 3 main scheme. Although we work very closely and we have the new ERA national policy, so we need to implement and for health system reform. This is all my presentation. Thank you.
Terima kasih. Thank you very much, Ms. Walauku, for your presentation. I think we've had the benefit of the 3 countries and 3 different perspectives. And your last point about we can learn from each other, which we must do, but also one must develop the system appropriate for one's own country and context. So we've got an opportunity now, I think, for probably about 20 minutes, 25 minutes for some questions. Hopefully people will be posting those through Slido. I know that Professor Kieran Patel has other commitments. So maybe if there are particular questions for Professor Kieran, we might be able to take those earlier rather than later before he has to leave us. Okay, at the moment we have one question, I think, from Nick in terms of how BPJS is improving its strategic purchasing. So I don't know whether or not, Ms. Lily, you were able to answer that one for us. No.
Mr. Nick, thank you for the questions. This is not an easy question, actually. For now, as you see in that a scheme that I have mentioned earlier, in purchasing, we still have limited roles there, such as for package of benefit and also the payment provider payment rates that is still determined by the government or Ministry of Health. What we can do in that area is only we try to involve and we do advocacy for the stakeholders to key stakeholders in establishing the regulation and policies to also so we give them some insights for that. Only right now that's the only thing we can do is to advocate the key stakeholders. But in our area, we can still do some strategy to make sure or to ensure that the benefit that is that we paid in the facility is according to the policy and policy and regulations. In managing healthcare providers, we will enhance the compliance of the health providers by monitoring regularly the commitment of the facilities to deliver the health service according to the agreement in the contract. And besides that, we also build some indicators to ensure and to improve the compliance of the healthcare providers. For instance, how to control the incidence of nosocomial, for instance, we put into indicators that we ask for the facilities to comply, so we can make sure that the members of JKN has received the healthcare service in a quality in healthcare services. And also in the hospital, because we use the INA-CBGs for payment, we must make sure that the service delivered is within the standard of care that is includes in the package. So we also and the third, we also doing some other payment methods such as global budget that will enhance the facility to deliver the service more efficiently and more quality with cost containment. And in the primary healthcare, we do capitation payment based on performance indicators such as teleconsultation. So whenever in this pandemic, in the era of pandemic where people were hesitate to come to the facility, then the facility itself has to reach for the member of JKN to make sure that they have their right to have access to the quality of health services. In that, there are some strategies that we do in our domain to make sure that we do have quite strategic purchasing in our area. Thank you. Only one question, I think. Yeah.
Sorry, thank you very much, Ms. Lily. Do we have any other questions? No. Okay, so I think.
Okay. Thank you for the questions. 30 baht scheme co-payment. As I present you, it's start from universal coverage is because of the government policy. So when it's changed the cabinet, so the policy is changed for co-payment. But we found that if compared with the total fund, it's very small. Why? Although it's come back, and 30 baht co-payment is will exemption since we start with the poor, the elderly, the children under 12, the disability. So just only half of the beneficiary need to pay co-payment. When the new government in 2006 have policy to exemption not to pay, is not effect to the system. So it's very small if compared with the total governments. The mechanism of global budget of the RG, as I mentioned, because we have very limited budgets, and mainly we use the budget of the government. So we need to implement the global budget. So we need to manage under the budget that we have. So we need to have the point system. In each quarter, we will proportion the point by the budget that we have. This is the mechanism that we do under the DRG with global budgets.
And maybe you answer, if you can respond to the next question as well, please.
Okay.
Welcome.
No, I think Thailand is we have the Act 18 year, but if you seen from Thailand, we have long struggling nearly 30 years before we develop achieve the universal coverage, not certain. So we use a very long more than 30 years to achieve the universal coverage. And the very important is we try to advocacy and promote for participation. If we involve all people to the system, we advocacy them, although the civic groups, they will understand the system and they can voice when they need. So every year, the government have to arrange the public hearing to answer their need, both from the providers, from the health facility professional, and also for the people. So the government can listen what they need, what the problem, and we try to work together.
Thank you. And you're very, very popular this afternoon. So one more question, I think, for you.
Yes, as we found that at this moment, especially the pandemic, the telemedicine, and also we need to implement out, and we plan that although the pandemic is solved, the telemedicine will be very helpful. We found that we can use very simple application like Line, but we can close contact with the people in the rural. So we found that the telemedicine via simple application is very important, and we will continue us improve and use it in our system.
Thank you. Perhaps I could ask my friend, Professor Ali Gufron Mukti, a question in terms of the Indonesian universal health coverage. What do you see, Prof. Gufron, as the main challenges at the moment?
Okay, I think there are many challenges, but if you ask about
Okay.
sorry, the battery is run out of battery. Again, I think the main challenge actually demand from the stakeholders, especially the hospitals and providers, and in quote also the important stakeholders.
Yeah.
First, that from the health facilities, they want increase the tariff. And if they increase the tariff, that is quite challenge, because as also in Thai or maybe also in UK, that the budget is limited. This is the first challenge. The second challenge, actually, like in Thailand, about universal health coverage scheme, the 30-baht policy, actually number of people are quite huge, and it is tax-based system. And in Indonesia, we are also having subsidized membership, especially for the poor and near poor. The problem, there is an issue, but not yet implemented, that this number of subsidized membership will be reduced. So if it is reduced, then it is challenge to achieve universal health coverage. Yeah, I think that two things, but of course there are still many challenges, but here, because you asked the main challenges, I think that two things. Thank you, Prof. Gaidali.
Thank you. Thank you, Prof. Gufron. Do we have any other questions in the Slido?
No, actually, if possible, also to ask Prof. Look, is it possible that you have 3 schemes? Indonesia now have 1 scheme. We jump from many schemes to 1 scheme. So as you mentioned that you have planned for healthcare reform, is there any possibilities in how many years in the next, is that do you have plan to merge into 1 scheme to make the equity among the 3 groups? And when maybe this will be, successfully merged, if it is planning? And of course, for the UK, I think there are many important things, but because of time, actually, there are many things to share maybe next time. Thank you.
Thank you for your question. As I mentioned in the presentation, although in the National Security Act, they mentioned we have to merge to be the single fund, but in the reality, you can see each scheme, they have their own acts and not easy. We try, because they have a one word in the act that 3 schemes have to work together and also have a change the acts method. So not easy if we not have the strong policy. So at this moment, we learn that it's difficult to merge to be the single fund. I think will be so mainly we try to harmonize. At this moment, although we have 3 main schemes, we work together. We use the same registration and mainly done by National Health Office because it will the main effect to us why we have the single beneficiary legislation, and also we use the same CPG. So the quality service and also the standard of service is the same. We use the same DRG because we have a Thai DRG, so we use the same DRG. We use the same standard of audit, so mainly we use the same principle. Just only some payment mechanism is still group and also political group that's not easy to be the single fund. So at this moment, we try to work together, and if we compare payment scheme, the benefit is quite similar. Just only one is different is payment mechanism. CSMBS still use the fee for service for outpatient. Why I mentioned in the challenge that treatment scheme is still inequity because the civil servant, the population just only 5%, 5 million, but they use the budget the same as tax base, half of 46 million people. This is a Thai challenge. Thank you.
Sorry, Prof. Gufran, do you want to come back in? I think you're on mute at the moment.
Huh?
Okay, now.
Oh, mute now? Okay. So for in Indonesia, if people have waiting time for elective operations more than 1 month, they will complain.
Yes.
So I just would like to know, because when your colleague presented in UK system, there is elective and non-elective surgery.
Yeah.
So do you have any figure, the mean of waiting time, or at least how many, how long the patient for elective surgery, they still can accommodate? Because in Indonesia, if more than 1 month or maybe more than 2 weeks, they already complains. Even this morning, I was complained by someone. Okay, thank you.
I think Prof. Kieran, as Prof. Kieran was saying, Prof. Gufron, what we saw initially as far as the pandemic was that nobody wanted to go into hospital because they were a bit scared of that. So we saw two things: waiting lists going up a bit because people wouldn't want to come in, so people waiting longer through their choice, but also undiagnosed health problems, which since we've had people coming to outpatients and needing to have elective interventions. The NHS constitution that Prof. Kieran mentioned has within it an expectation that people will have a period of 18 weeks from referral to treatment normally. But with the pandemic, we have seen a massive increase in people waiting longer than 18 weeks, and a real rise in the numbers of people waiting a long time, 6 months or more, which is why we had the UK government announce the increase in social insurance of 1.5% for the next 3 years to cover the backlog in the NHS, which is fantastic. However, as Prof. Kieran was saying, you still need to have the supply side readiness. You need to have the capacity. And that's partly about having the technology, but it's also about having the health workforce to be able to respond and supply against that increase in demand. So we have similar challenges.
Thank you.
Okay. Any other questions? Okay. So I will try. There's a question: what's the NHS strategies to manage healthcare costs in the future without decreasing the quality of care? I think there's a number of things. We have, for some time, we've had NICE, National Institute for Clinical Excellence, which determines what treatments are permitted and not permitted. So we have that. We also have quality assurance to ensure that interventions are effective or not, which again, Prof. Kieran, I think, was talking about. Instead of measuring inputs, we measure outcomes. Has it improved somebody's health status? I think another thing that we are doing is we're trying to make sure that our system is joined up and integrated. So there's legislation happening at the moment whereby we are moving away from the purchaser provider system to one of more partnership and collaboration, particularly across sectors. So, for example, what we call social care, that's caring for people with comorbidities over a longer period of time, mainly in their own home, but sometime in residential care. We have to ensure that that is working okay, because if it doesn't, then we get blockages of the system. We get people staying in acute, secondary and tertiary hospitals when they no longer need to, because we haven't got somewhere else for them to go to be cared for in an appropriate way. So one of the challenges that we're trying to meet at the moment is to ensure that we get integration across our system, as well as the other things I mentioned. Okay, there is a question from Echo, I think. JKN Indonesia, there is a discourse that a co-payment will be applied for high-cost diseases. Will it be implemented? And secondly, what are the results of the implementation of global budget payments in several hospitals in Indonesia? I don't know whether that is something that either Ms. Lily or Prof. Fali Gufron might be able to respond to.
Okay, thank you. I would like to answer first, and maybe if Prof. Gufron will edit something, please. The first is that the co-payment, there is a discourse that co-payment will be applied for high-cost disease. it is still ongoing discussion within government ministries and other sectors. So I cannot say, I cannot definitely say something about this because it is still on process. So we don't know yet whether or not a co-payment will be applied for high-cost disease in the near future. And the second, the global budget payments that we have already conducted tryouts in several hospitals in Indonesia. To this time, showing quite a good results, but it still needs long-term evaluations. So we are trying to have more hospitals in trials in global budget payments. But some good points is that in global budget payments, the hospital is trying to deliver care in some in accordance to the quality control and cost containment, because they have this some kind of plafond on the budget that is given by them, so they can plan how to deliver a service for certain times. And one more benefit is that they concerned about this referral back program. So for chronic disease, they don't keep the chronic disease patients longer in the tertiary and secondary hospitals. They tend to refer back and get the primary facilities care, doing the maintenance of this chronic disease. That's what I can share, but we still ongoing evaluation. So this is a long-term evaluation of these payment methods. Maybe okay. I think that's.
Thank you, Ms. Lily. Okay, so perhaps if it's okay with everybody, we probably need to start to bring things to a conclusion. I know that there are some other questions. I apologize that we're not able to cover those, but we're nearly at 5 o'clock in the afternoon in Indonesia and 11 o'clock in the UK. So if I can, I'd just like to say thank you to our speakers. So first of all, to Prof. Aligo from Mukti for opening today's webinar, and then to Ms. Lily, Prof. Kieran, and Ms. Wiloku for your presentations. I think they've been most informative, and we're continuing to therefore have opportunities to learn from each other so that we can make improvements to our own individual country's healthcare system. And I think that we can adapt and adopt from learning from each other. Similar challenges, obviously, that we have in terms of aspects such as funding, supply side readiness, not least the workforce. And in addition, that whilst one will see continued improvements in population health, in individual health through the better provision of healthcare services, we must also remember that it is the public health upstream activities, the social determinants of health, that we must also tackle, because they play as big a part, if not a bigger part, in determining the health status of individuals and their populations. But an absolutely fantastic afternoon or morning, as far as I'm concerned. I hope that everybody stays well and that we're able to meet again, either virtually or even better, in person in the near future. Thank you. Terima kasih.
Thank you. Terima kasih.
Thank you. Thank you, Prof. Delhi. Thank you so much, Prof. Deli, for your leading of this discussion. And ladies and gentlemen, we've almost completed today's event. I would like to express my gratitude to the speakers today. For the first, Ibu Lili Krisnawati, terima kasih banyak, Ibu. And the second, Miss Wilaylu Pisasa, Kopunkap. And then Professor Kieran Patel, thank you so much. He has left because of another agenda, but no problem. Best wishes for you, Professor Kieran Patel. And then thank you so much for our great moderator today, Prof. Guy Deli from Coventry University. Thank you so much. May these partnerships getting stronger in the future. And also thank you for up to 500 participants in this international webinar. Allow me to close this webinar with a quote from Insinyur Soekarno, the first president of Indonesia. Build the world where all nations live in peace and unity. Thank you, stay healthy and have a nice day. Wassalamualaikum warahmatullahi wabarakatuh.